Hello and welcome to this talk on the anesthesia management of electroconvulsive therapy or ECT. In anesthesia and surgery, it's often hard to understand why things are the way they are today if you're not familiar with their historical development. Well, this may surprise you, but it really is essential if you want everything that follows to make some sense. The role of anesthesia in the development of ECT is no different. So, I'm going to start this presentation with a very brief synopsis of the milestones in the developments in electroconvulsive therapy. It's important. And the role of anesthesia in ECT is very important. So, in the 16th century, various agents were being used to induce seizures, and the seizures were being used to treat psychiatric conditions. And in 1785, the use of therapeutic seizure induction was documented in the London Medical Journal. So as you can see, this phenomena goes back several hundred years. In 1934, a Hungarian neuropsychiatrist, Ladislas J. Meduna, induced seizures using oral camphor and later with Metoprolol, or a drug called Cardiovascular, and he is known as the father of convulsive therapy. By 1940, Cardiovascular convulsive therapy was being used worldwide in preference to camphor, and in the 1930s, an Italian professor of neuropsychiatry called Ugo Saletti had heard that pigs given an electric shock to the head before being butchered at the abattoir entered an anesthesia-like state. A colleague of Saletti's, called Lucio Bini, developed the idea of using electricity as a substitute for Metoprolol. Together, they experimented with the delivery of an electrical shock to the head to produce convulsions in dogs. In 1938, a milestone was reached when Ugo Saletti and Lucio Bini experimented using sinusoidal electrical current therapy instead of Metoprolol for the first time on a human subject to induce a seizure. The physiology of this situation is really very interesting. Saletti and Bini experimented diligently until they identified appropriate electrical parameters for a successful human trial. They started patient trials and they produced significant improvement in their patients after about 10 to 20 treatments. They noted that, fortunately, there was retrograde amnesia which prevented their patients having an adverse perception of the experience. Practitioners of convulsive therapy worldwide soon abandoned Metoprolol therapy because ECT, electrical induction of a seizure, was cheaper, less frightening for the patients, and was much more convenient. In the 1940s, electroconvulsive therapy was introduced to both England and the United States, and through the 1940s and 50s, the use of ECT became widespread. During this time, ECT was still unmodified. That is, it was administered without a muscle relaxant, and this led to rare but very severe fractures or dislocations of the long bones and joints. So this was a major problem for patients having ECT. Something had to be done. In the 1940s, modification of the seizure with curare was introduced, but because of the prolonged duration of action of this muscle relaxant, modification of the seizure in this way was unpopular. Muscle relaxant modification led to an intensely frightening feeling of the inability to breathe, and in response, for the first time, short-acting general anesthetics were administered for this sense of dyspnea, this sense of being unable to breathe. So, the anesthesia was not given to obtune the experience of the electrical shock. It was simply for the difficulty of breathing because of the technique used to modify the muscle contraction. In 1951, however, the introduction of succinylcholine, or succinylcholine, for modified ECT dramatically increased the popularity of ECT because there were not the problems of prolonged muscle weakness causing problems with breathing. In most of Europe and North America in the 1700s, now I know we're jumping back a long way, but in the 1700s the Industrial Revolution caused the movement of populations from the countryside to the cities to supply labour to this new phenomena of industrial factories. The arrival of large numbers of people in towns and cities rapidly caused overcrowding, and the primitive sewage systems and water supply systems could not cope. These were the ideal conditions for the spread of infectious disease such as pulmonary tuberculosis, and this led to a frequent cycle of TB infection, recovery, and then reinfection with TB. And to break this cycle, many cities established tuberculosis sanitaria at a distance, way out in the countryside, for the benefits of fresh air and the remoteness of the location would make it difficult for people to walk back to the cities to reinfect or to be reinfected by family and friends. So what's the possible relevance of this to ECT? Well, you'll see. Please indulge me, we'll get there. When the scourge of pulmonary tuberculosis was finally conquered, these sanitaria fell empty, and authorities sought a new use for them. As yet, psychiatry was in its very infancy and really had very few effective psychiatric therapies. It did not take long for the growing population of untreatable psychiatric patients to be removed far from the city and placed in these remote locations, and instead of sanitaria or hospitals, these places were referred to as asylums, mental asylums. This was a place to hide the mentally ill. And so while the wisdom of this approach may be questioned from our perspective, it did concentrate patients with both major depressive diseases and psychotic disorders all in one place. Some of these patients also had epilepsy, and their medical attendants could not but help notice that there was a brief but dramatic improvement in depressed and psychotic patients immediately after they had a seizure. Many physicians despaired for their most chronic, totally untreatable patients. They were consigned to living the rest of their days locked in the insane ward. And by the 1940s, interest in this new phenomena of electroconvulsive therapy was growing, both in North America and the rest of Europe. There had been a focus of interest in Italy, but it was now spreading throughout the rest of Europe. And it offered hope for some of the worst asylum inmates. Some physicians caring for severely depressed or psychotic patients in these large mental hospitals were now more than ready to exploit any possibility that might help their most desperate patients. They were already open to the beneficial effects of seizures, and they were enthusiastic about the use of electricity to generate a seizure. In the absence of any reasonable alternatives, it did not take long for physicians to embark upon this novel way of inducing seizures in order to treat what were incredibly, profoundly disabling mental conditions. It's hard for us to appreciate it because we rarely see such large numbers of mentally disabled patients as they were seeing a couple of hundred years ago. The early history of convulsive therapy in psychiatry relied on inducing seizures with camphor or cardiazol. Another early technique was insulin-induced hypoglycemic seizure, and a particularly fine recreation of such a treatment episode may be seen by the actor Russell Crowe in his depiction of Princeton mathematician John Nash's experience of this, when he was strapped to a bed by leather straps and he experienced a violent hypoglycemic seizure. Multiple other techniques were being used around the world to induce seizures, many potentially damaging, particularly camphor, intravenous camphor, until the introduction of electricity to precipitate a seizure in what we now refer to as electroconvulsive therapy or ECT. And I know that currently this is somewhat controversial therapy, but there can be no doubt of its efficacy in carefully selected severe patients who are totally refractory to conventional antidepressants or antipsychotic medication. I firmly believe it has a role in highly selective patients, but it must not be used indiscriminately. ECT is occasionally the only hope for patients who have failed conventional treatments and who have conditions in which conventional antidepressants and antipsychotics are contraindicated, and it absolutely must not be used for control of behaviour. And this is due to abnormal activity in the pyramidal motor system. So let's consider both normal and abnormal activity in the pyramidal motor system. But just indulge me a second because this is important. When I want to flex my bicep muscle, it's well known that nerve impulses arrive from my prefrontal cortex. They arrive at the muscle and they cause flexion in the muscle, contraction in the biceps. What is generally forgotten is that there is a simultaneous nerve impulse inhibiting contraction in those muscles which are antagonistic to the biceps, for example, principally the triceps. And this is logical because in many situations it would be most inefficient to have simultaneous contraction in both the biceps and the triceps, as these muscles would be fighting each other. Understanding this concept of reciprocal inhibition is important. The well-synchronized contraction of the agonist muscle and the relaxation of the antagonist muscle applies to almost all muscle groups. However, during a seizure, there is a completely non-physiological activation of motor cells in a large area of the affected motor cortex, leading to simultaneous powerful contractions of both agonist and antagonist muscle groups. This chaotic muscle activity places joints under extreme forces. It's a very unphysiological situation, it's very abnormal, and it can cause severe musculoskeletal damage. Tendons can snap, ligaments can rip or be damaged in other ways, joints can be dislocated, and tendon bony insertions may be pulled apart away from the bone. Very muscular patients, like bodybuilders, are at risk of severe musculoskeletal damage. And at the other end of the spectrum, our elderly osteoporotic patients' bones can be fractured. For this reason, the strength of the muscle contraction during an induced seizure must be reduced. And this is done by administering a small dose of a short-acting muscle relaxant, such as succinylcholine. This is what we call a modified seizure, and it's important. It's a very important topic to address. We refer to such grand mal seizures with generalized markedly weakened muscle contractions as being modified. But the term modified is important. Modification of the seizure is particularly important in patients with fragile bones, in patients with very large, powerful muscles, such as bodybuilders, and in those patients at risk of joint dislocation, such as patients with joint replacements. Particular concern would, of course, be the extreme example of a patient with osteogenesis imperfecta. But bear in mind, however, that psychiatrists do want to visually witness the intensity of the seizure, despite the concomitant use of EEG monitoring, because the intensity of the physical seizure provides some evidence of the intensity of the seizure. The implication of this is that we must avoid total paralysis of the patients. We want to see a modified, weakened seizure, a modified motor response. And so for a normal 72 kilogram patient without major musculoskeletal issues, a dose of succinylcholine of approximately 1 milligram per kilo would be quite appropriate. The intensity of the electrical seizure and the intensity of the muscle contractions has prognostic value for a response to the seizure. Note, for those psychiatrists who would like to witness the intensity of the unmodified seizure, the isolated arm technique may be used, but we're going to consider this a little later. Electrical therapy has established itself as the best technique for inducing a therapeutic seizure. Of course, the application of an electrical current across the patient's head is painful, and it is a given that we must do whatever we can to prevent such a distressing experience. To this end, anesthesiologists must provide brief general anesthesia to prevent such discomfort. But unfortunately, most of our intravenous and inhalational anesthetic agents are potently anti-seizure and will reduce the quality and the efficacy of an induced seizure. So let's talk about the pharmacology of the induction agents for ECT. Anesthetic induction agents generally, such as Propofol, Pentothal, even sevoflurane, are anti-seizure. The exceptions are METHOHEXITAL and etomidate, which are pro-ictal. The status of ketamine is as yet undetermined due to conflicting results in the literature. The role of ketamine currently is that it is an adjunct to other induction agents rather than a sole anesthetic for induction. Seizure threshold generally increases over a course of ECT, which is 2 to 3 treatments per week over 2 to 4 weeks, and the initial dose is determined by the patient's body weight. Subsequent doses must be modified based on previous responses to ECT versus changes in seizure threshold. The general aims of the choice of dose of induction agent is to decrease the dose of induction agent to the minimum consistent with lack of awareness, because lower doses may intensify and prolong seizure duration. METHOHEXITAL is least anticonvulsant, and it produces myoclonus by virtue of increasing neuronal excitability and thus decreasing the seizure threshold, and some consider it the gold standard for ECT induction. Pentothal is used worldwide, but it has become unavailable in North America. It's manufactured in Italy, and the Italian government will not allow its export to the US because of its use in the death penalty, a use of which the Italian government heartily disapprove. But Pentothal is so powerfully anti-seizure that few would choose it for ECT anyway. There are reports that etomidate produces the longest seizure duration. It may be doing this by reducing seizure threshold, and so like METHOHEXITAL, it also can cause myoclonus. Post-operative nausea and vomiting is common with etomidate, and it may be severe, so it may be a poor choice of patients needing early recovery and discharge. A recent systematic review concluded that all currently available induction agents are suitable, or in other words, adequate for ECT, but not necessarily good or the best. And the small variations in emergence and recovery profile times should not govern drug choice. But our state of knowledge of this area is lamentably lacking. More work needs to be done. Some anesthesiologists feel that whichever drug is used, it is preferable to utilize the same one throughout a course of treatment. And this is to avoid interfering with the seizure threshold, which, as I said earlier, generally increases over the course of ECT. However, if the seizure threshold has been increasing to a point that seizure duration and intensity is poor, a change of induction is reasonable. It's often, but not always helpful. Often helpful, but not always. The addition of ketamine 50 milligrams IV, or a short-acting opioid such as remifentanil, or even alfentanil, these have very significant dose-sparing effects on your induction agent, allowing an increased seizure duration with agents such as Propofol and METHOHEXITAL at a lower induction dose. But this is not the case with etomidate, unfortunately. Fortunately, METHOHEXITAL, ketamine and Propofol are frequently satisfactory for use in ECT. And as I've said before, we try to minimize the dose. Inter-individual variation in response is common, and the use of a particular agent does need to be tailored to the response of the individual patient. METHOHEXITAL is popular because, unlike many induction agents, its reduction of seizure threshold makes the occurrence of an acceptable seizure much more likely, and it makes an intense seizure more common. Propofol for use in ECT is a really complex topic. In many patients, Propofol permits an excellent seizure, but in occasional patients it seems to be absolutely anti-seizure, and it's again, its use in individual patients depends on their response, and this is impossible to predict beforehand. Ketamine is a useful intravenous adjunct which allows for a reduced dose of induction agent, and it may be used in depressed patients needing ECT. Some psychiatrists particularly request the administration of ketamine during ECT on the basis of some studies that have shown a reduced incidence of recurrent depression up to 2 years after administration of the ketamine. Now, this is an early finding. It has not yet been confirmed. Ketamine's propensity for illusions and hallucinations, however, means that it may be best to avoid it in some psychotic patients. And again, while these results require confirmation and the characteristics of patients with the potential to benefit from ketamine need to be more clearly identified, at the moment, ketamine remains a popular adjunct to other intravenous hypnotic agents. The most basic criteria to judge treatment efficacy is a seizure duration of greater than 30 seconds with good seizure intensity. In my practice, the administration of 50 milligrams of ketamine at induction allows for a significant reduction in the dose of either propofol or methohexitone, and this combination may actually predispose to improved seizures, but further work to confirm or refute this impression is required. The choice of these agents for ECT may be best characterized as choosing that agent which provides the best possible seizure at the lowest possible effective dose. Prescribing guidelines in ECT patients. Avoid polypharmacy in these patients. If the seizure is suboptimal, almost any drug could be implicated for a possibly idiosyncratic anti-seizure effect. These patients generally do not need routine narcotic analgesics or antiemetics, and so only prescribe a particular medication when the need for that medication is pressing and it will not compromise the seizure. Avoid all anticonvulsants, of course, especially the benzodiazepines, and particularly I have in mind midazolam and diazepam. Avoid or discontinue a patient's anti-epileptic medication, and avoid membrane stabilizers such as the group 1 antiarrhythmics, and I refer here particularly to lidocaine. Do not give lidocaine. A conventional course of ECT is often 12 treatment sessions. It is useful to approach each individual treatment episode as a trial aimed to determine the best agent and the best dose for any particular patient. For example, in my own practice, I like to start with Propofol 1 milligram per kilo, and if the seizure response is suboptimal, I will reduce the dose to the minimum consistent with lack of awareness. If there is no improvement in seizure duration after 2 or 3 treatments, I will abandon the Propofol and change to methohexitone at 1 milligram per kilo. Subsequently, with the agreement of the psychiatrist, I will add in ketamine with reduction of the dose of the induction agent by 30 to 50% possibly. Optimal ECT anesthesia requires a minimal effective dose of induction agent, but how do we know what dose is effective at obtunding awareness when a patient is paralyzed? This is a pretty challenging question. Could the patient remain aware but unable to move? Obviously, we cannot detect light anesthesia with a bispectral index monitor or BIS monitor because it requires electrodes on the patient's head, exactly where the delivery electrodes are positioned for the ECT. Some anesthesia providers favor the use of the isolated arm technique. This works as follows. After induction, a blood pressure cuff tourniquet is inflated to above systolic pressure immediately prior to the administration of the succinylcholine. Then, just prior to delivery of the electrical impulse, the patient is asked to use the isolated hand to squeeze the anesthesiologist's fingers. If he can, of course, if he can hear the voice. If the patient responds, then additional anesthesia agent is obviously needed. If not, the electrical therapy may be delivered. The isolated arm technique is occasionally a useful approach to prevent awareness of the electrical stimulus, although there are lots and lots of false positives and false negatives. For example, methohexitone is well known for producing myoclonus, and the patient can be deeply anesthetized, but their hand may twitch, or there may be a palmar grasp reflex. So although the patient is asleep, they may actually, this response may be interpreted as the patient being aware. Movement of the hand does not always imply awareness under anesthesia. Again, because spontaneous myoclonus can occur. But also the failure to respond does not guarantee absence of awareness. Awareness occurring in a catatonic patient or a psychotic patient can occur without the patient responding with their fingers. So despite our best efforts, the seizure response to ECT may be suboptimal, and the anesthesiologist is faced with attempting interventions to improve seizure duration. Now, it's been known for a long time that high doses of IV caffeine in patients with predisposition to it can actually precipitate a seizure. And we can use this to good effect with a dose of IV caffeine, caffeine with sodium benzoate or caffeine citrate, 500 milligrams, or 5 to 10 milligrams per kilo, 5 minutes before delivery of the electrical stimulus. And this will often improve seizure responses. Doses in excess of 2 grams have been used to good effect. Now, please indulge me for a moment as yet again I will appear to go entirely off topic. While most children are quite happy at school, some are not too pleased to be there, and they pursue all sorts of ways to be sent home. Now, some children are in fact very successful at doing just this. One popular technique among such youngsters is to hyperventilate themselves to the point of causing dizziness and ultimately loss of consciousness, causing them to collapse in class. This results in a very alarmed teacher, and then the child, as soon as they're recovered, they're sent to the school nurse, who then immediately arranges for them to go home. Exactly the result the child intended. Some children doing this simply try too hard, and occasionally they hyperventilate themselves to a point where not only do they lose consciousness, but the hyperventilation generates a respiratory alkalosis with cerebral vasoconstriction, and this situation can proceed to a full-blown grand mal seizure. It's quite amazing what these kids get up to. The point of this is that hyperventilation is very effective at reducing seizure threshold, and this fact is corroborated by the frequent occurrence of seizures in patients presenting to the ER with panic attacks who've hyperventilated themselves for protracted periods and then end up having a seizure. Now, shortly after induction of anesthesia and the administration of a muscle relaxant for ECT, we can spend a minute or two hyperventilating our patients to reduce seizure threshold, and this will hopefully produce longer and more intense seizures. Now, of course, there are other ways of augmenting a seizure during ECT, but hyperventilation and IV caffeine pre-treatment are the most popular. And the others are unfortunately beyond the scope of this discussion, but they do exist. ECT has been associated with adverse cardiac events in elderly patients, so it's also very important for us to be familiar with the cardiovascular effects of an electrically induced seizure. We're going to discuss that now. Many elderly patients experiencing ECT have cardiovascular disease, and major adverse cardiac events, or MACE, may be related to these cardiovascular events which occur during ECT. In the same way that the pyramidal motor system and the centers of consciousness are scrambled by a grand mal seizure, the autonomic nervous system appears to experience something similar, a type of convulsion. The first cardiovascular response to an electrically induced seizure is electrical stimulation of the dorsal motor nucleus of the vagus nerve, and this produces a marked sinus bradycardia, even possibly a brief period of sinus arrest, also known as, of course, asystole. It's usually of a very short duration, and as such is sometimes termed a sinus pause. However, in some patients, the period of sinus arrest or asystole can be alarming. Now, after a few seconds, this usually resolves to be replaced with marked and sometimes intense sympathetic nervous system stimulation. In the general operating rooms, we've been told, of course, that elderly patients at risk of MACE who are hypertensive and tachycardic will benefit from beta blockers. And before starting ECT, some operators administer beta blockers preemptively. On the face of it, this may seem very reasonable. However, the downside is that beta blockers may convert the initial vagal phase from what would have been a marked bradycardia into an episode of actual asystole, and this may not always spontaneously resolve. Unfortunately, fatal cardiac arrest in asystole is well documented after ECT, but it is unfortunately uncommon. If the patient requires an antihypertensive to prevent an unacceptable increase in blood pressure response, it's my practice to wait until after the vagal response has subsided and then administer an appropriate dose of beta blocker to the patient as soon as possible before the sympathetic response becomes well established. The psychiatrist is, of course, very interested in observing the patient's EEG trace during ECT, and we must not interfere with this. If we touch or move the patient during the seizure, it can interfere with analysis of the EEG trace. So administration of drugs need to be cautious so that we don't physically interfere with the EEG tracing by touching the patient. So if the patient has an IV with IV fluid running through it, or if they have an extension to their intravenous cannula, it's simply a matter of administering meds through the tubing without ever touching the patient. Metoprolol 1 to 3 milligrams IV may be given after the vagal phase and very early in the sympathetic activation phase. This dose may be repeated once if indicated, and is often an appropriate choice. On the other hand, some patients present already maintained on beta blockers, and they present with marked sinus bradycardia. It's reasonable to pre-treat these patients with glycopyrrolate 0.2 to 0.4 several minutes before delivery of the shock to prevent further slowing during the vagal phase and hopefully decrease the risk of asystole. By the same considerations discussed above, this may unfortunately augment the heart rate during the sympathetic phase with both unacceptable tachycardia and hypertension. And again, this can be prevented by the appropriate choice of an intravenous beta blocker, a cardioselective beta blocker, early in the phase of sympathetic response to ECT. So although ECT is a brief anesthetic, not requiring endotracheal intubation, this may be the reason that it's thought to be a lower quality anesthetic. That is, people take it less seriously. They have many patients to do, so they rush through. But failure to apply the same stringent standards for high quality anesthesia care, including careful cardiac evaluation to the ECT patient, as we do for our other operating room patients, may be a major factor contributing to the incidence of MACE in our elderly patients for ECT. These patients are sometimes very sick, and they deserve the same high quality care we give to our patients in the general operating rooms. So, please take the administration of anesthesia for ECT in patients with cardiac disease very, very seriously. And in fact, we should take it very, very seriously for each and every patient. I hope this presentation has been useful to you. Please feel free to adopt anything of which you approve in my presentation, modify anything that you feel is appropriate to be modified, and to totally disregard anything with which you heartily disagree. I wish you the very best success in the future care of your patients for anesthesia for ECT. Remember, in the practice of anesthesia, knowledge is power. Thank you for listening to my presentation.